Sickle cell disease and elective cholecystectomy. Welcome to the Everything Surgery podcast, where today we are delving into the intricate relationship between sickle cell disease and elective gallbladder removal. Patients living with sickle cell disease who require this surgery face a significantly higher risk of complications during the perioperative period. These complications can include vaso-occlusive crises and acute chest syndrome. Achieving a positive outcome demands a well-coordinated team and careful management throughout every stage of care. Preoperative strategies before surgery. The primary goal is to optimize the patient's blood and reduce triggers that can cause sickling. Let's walk through the essential steps taken in this phase. Comprehensive team assessment. This step involves assembling a team that includes a hematologist, surgeon, and anesthesiologist. Together, they examine the patient's history of previous crises, current blood count, and any organ damage present. Blood transfusion preparation. The aim here is to decrease the proportion of sickle hemoglobin and correct severe anemia. For surgeries with significant risk, the target is often a hemoglobin level around 10 grams per deciliter and sickle hemoglobin below 30 to 40%. This plan is adjusted for each patient, balancing the benefits against risks such as immunization and delayed transfusion reactions. Hydration and fasting management. Individuals with sickle cell disease are more prone to dehydration due to their kidneys' reduced ability to concentrate urine. To counteract this, fasting times before surgery are kept short and intravenous hydration is initiated with balanced fluids to prevent dehydration and increased blood thickness. Infection prevention. Strict aseptic measures are maintained, and it is vital to confirm all recommended vaccinations are current, especially since these patients are at risk for functional hyposplenism. Intraoperative strategies during the surgery itself. The anesthetic and surgical team must focus on preventing triggers that can lead to a sickle cell crisis. Here are the main points. Preventing crisis triggers. It is essential to avoid low oxygen levels, low body temperature, acidosis, and reduced blood volume. This is achieved by using warmed intravenous fluids, warming blankets, and careful ventilator settings to keep carbon dioxide levels stable. Choice of anesthesia. Both general and regional anesthesia are viable options. The choice depends on the patient and the surgical plan, with an emphasis on keeping blood pressure and heart rate steady. Regional anesthesia can offer excellent pain control after surgery and may provide additional stability in patients with liver involvement. Monitoring and access. Standard monitors are used, along with temperature monitoring. An arterial line is highly valuable for continuous blood pressure measurement and frequent blood tests, allowing early detection of acidosis or low oxygen. Surgical approach. The laparoscopic method is preferred for gallbladder removal, as it is linked to quicker recovery. Caution is exercised during the introduction of carbon dioxide into the abdomen, keeping pressures low to reduce breathing complications and referred shoulder pain, especially if regional anesthesia is used. Post-operative strategies after surgery. The risk of complications remains high, so careful observation is crucial. Let's discuss the steps taken in the recovery phase. Close monitoring and oxygen support. Patients are observed in a high-dependency unit for signs of acute chest syndrome or vaso-occlusive crisis. Supplemental oxygen is provided to maintain oxygen saturation above 94%, and incentive spirometry is encouraged to prevent lung collapse, which can lead to acute chest syndrome. Multimodal pain control. Effective pain management is vital, as pain can set off sickling and shallow breathing. A combination of pain relief methods is used, including regional anesthesia if available, nonsteroidal anti-inflammatory drugs with caution regarding kidney health, and opioids to minimize sedation and breathing depression. Hydration and early movement. Intravenous fluids are continued until the patient can reliably drink. Early mobilization and mechanical methods to prevent blood clots are encouraged, as individuals with sickle cell disease are at increased risk for vein thrombosis. Watchfulness for complications. The care team remains alert for signs of vaso-occlusive crisis, acute chest syndrome, infection, or bleeding. There are cases where patients have experienced severe bleeding after what appeared to be a routine surgery, requiring urgent transfusions and further surgical intervention. This underscores the importance of close monitoring during the recovery phase. To sum up, elective gallbladder removal in patients with sickle cell disease is a procedure with increased risks, but with a standardized, multidisciplinary plan that avoids common triggers and maintains physiological stability. Successful outcomes are achievable. The foundation of care lies in attention to detail throughout preoperative, intraoperative, and post-operative phases. Thank you for joining us today. If you found this episode informative, remember to like, share, and subscribe. This is the Everything Surgery Podcast, where we dissect the extraordinary.